Here is part 2 of my conversation with Dr. Tracy Hoeg. Right, it's been pretty interesting, just again as a layperson who got thrust into this world very much against my will, when the world of singers came crashing down because the news articles in May of 2020 of just like singing is the most dangerous thing you do. Every time you open your mouth to sing, you're basically shooting machine gun bullets at people's face. That was essentially the way that the news covered our profession, and so got thrown into it in that way and started immersing myself, not because I thought I could become an expert, but because when I had these conversations, I wanted to not sound like a moron, and started coming across just some of the general terms that you probably take for granted as an epidemiologist, of the ways you describe diseases, the way you describe health issues, and very much like you explained very well a minute ago, you've got to explain it in these big picture terms. You don't, epidemiologists, at least prior to the pandemic, didn't seem to use terms like can or could, like kids can die or people can die, because that again implies that the risk is not zero. They would use terms like at what rate do they die? And right now, I see people in your profession very much taking a different stance than you are taking, which is to use nebulous terms like can and could, and because it can happen, we should,
right, because you can't be wrong if you say it can happen, right?
Right. Yeah.
It's
exactly.
like, well, yes, it could happen.
Yeah.
But
Yeah.
how often? Yeah.
And one of the first ones I noticed, and I want to see if you've ever noticed this, and I'm interested in your theory. The first one I noticed very clearly about a year ago was I learned the difference between case fatality rate and infection fatality rate. I had never heard those terms before May or March of 2020. And I'm going on and reading, Mayo Clinic's website. I'm going World in Data, had a definition. I'm like coming up with these, like a concept. Oh, okay. So case fatality rate is going to be a higher number because it's your confirmed cases, and then you divide the number of deaths. That gives you a term. And that's really valuable for healthcare workers, because they know that if that person shows up at their doorstep with that disease, they've already, they're sick. And it gives them a concept of what is the danger here. But infection fatality rate has to, estimate from the broader population who's actually had this disease. And these were, correct me if I'm wrong, totally normal numbers to use and calculate in epidemiology prior to the pandemic.
Oh, for sure.
Okay.
Yeah, definitely. Not controversial terms. Yeah.
Not controversial terms at all.
Yeah.
But one of the things that we keep hearing people will say, this virus has like a 0.6% mortality rate. And then you'll hear people in your profession, public health people, turn around and say that that's misinformation. And then I will see them very clearly calculate for people on the internet case fatality rate. So in other words, somebody will come and say, I'm going to give you what I think is the infection fatality rate. And then a public health person, I've seen this 10 times now, will respond back with no. And they won't even mention that there's a discrepancy in terms. They'll just give case fatality rate.
Right, exactly. I mean, yeah, no, I mean, it proves the point that obviously you can use numbers to fit your narrative, right? But it's also like, well, why are we assuming that people are either good or bad? I think this is what I want to get to. Like, why are we looking for certain words to figure out whether or not we like or dislike a person? Like, I just feel like we should be actually looking for information, yes. and and it's really disturbing to me the way that people are kind of like so lazy that they don't seem to read what people are actually saying, but they look for certain phrases or certain, uses of, words, and then they say, oh, wrong team. And I just think it's so sad. And I just wish that people listening to this, would kind of think about that, and whether or not we really, all human beings are on two different sides. Like, does that make any sense? It doesn't make any sense. We all want the best thing for kids. We all want the best thing for all of us,
Right.
So I think that for me, having spent a lot of my adult life in Europe, I'm used to multi-party political systems and discussions that involve many sides, and open discussions, and I'm seeing that disappearing in the United States right now. It's very concerning, because how can you discuss ideas and trade-offs and different sides of a problem if you're immediately shut down just because you use a word like
right.
like infection fatality rate or phrase or whatever. Like, it's very dangerous.
Yeah. Yeah, it is. No, it absolutely is. And I don't remember if this came up in November when you were on with me before. I know I've talked about it on the show before, but the way I've processed all of this, of course, the thing I care about, I mentioned this before, where everybody kind of has a thing about COVID that they really are passionate about because it's what's touched their own life. Yeah. For me, I work with teenagers. And so I see the data on how COVID affects teenagers, all the way from severe disease to hospitalization to death. And I see data from authoritative sources, the WHO, CDC, and dozens others, peer-reviewed studies at this point, of what that looks like for them. And I do math in my head. And I also have, in the last year, had, I won't say how many, but several of my own students attempt suicide, start psych meds for the first time in their life because they are completely feeling despair and hopelessness. That scares me more than COVID does for those kids, because I know, and because I've also been affected in my teaching career with a successful suicide attempt from one of my close students. The infection or the case fatality rate of a successful suicide is 100%.
Yeah.
And so what frustrates me with this dialogue is that when someone hears me talk about how I'm more concerned about these school disruptions for kids than I am about COVID, because of the team thing you mentioned before, they hear, well, then you don't care about kids who die of COVID. But at the same time, I would never turn around to you and say, well, I guess you don't care about suicide.
I know. Why can't we care about both? I mean,
care about both.
Yeah, exactly. I mean, obviously, I don't know, that narrative about the suicides is just, it's very, I don't know, it's very bizarre, because it's like, well, we're seeing it borne out in the data, the epidemiological data, that we are seeing higher rates of it. We're definitely seeing higher rates of depression and mental health admissions. And so, I just don't feel like, if there is a higher chance of a child, any given child, dying of suicide than there is from COVID, right?
Yeah.
And so we should be paying attention to preventing suicides. We shouldn't not be doing anything to, prevent suicide. So if we're concerned about that, we need to address that. And that doesn't mean that we stop caring about kids who could potentially die of COVID, but, comparatively, the risk of suicide in kids is higher, in terms of death. So yeah, I don't know. That shouldn't be controversial, but it probably will be. But
no, it's remarkable. I mean, there are a lot of things that are pose a higher risk to kids than COVID. I mean, there are a lot of things, and if we're going to follow these rhetorical rules, I could yell at anybody on Twitter for not caring if kids die of cancer, because I haven't seen you tweet about child cancer in the last day. Like what are we doing to each other? Instead, we should, I would think, assume that the other person might care about a different aspect of what's going on right now than I do, because they have different life experiences in the last year and a half that I do. That's my assumption, but I think we've forgotten how to do that.
Right. And I want to give a quick, extreme example of our inability to do basically a harm benefit or risk benefit analysis with this. So there was I've been looking a lot into youth sports, and I'm really interested in studying it. And, I do sports and medicine, and see kids who play sports, and my kids are in sports. So anyway, so there was a study over the summer, 90,000 kids playing soccer, youth sports. And there was one case of COVID transmission that was attributed to the soccer practices of all 90,000 kids. Now, this was outdoors, right? This was last summer. And even after that study came out, like, it was still, they were still closing down all youth sports in California for the entire fall. And there are so many mental and physical health benefits to youth sports. And the fact that they weren't even allowing them outdoors was just like, how can we possibly be so off on this risk benefit analysis that if COVID is like the least likely situation to spread COVID is being outside, with kids who are low risk, and we're not even letting them do that. And we're putting them in higher risk situations.
But it can happen.
Right.
It can happen.
But that's the other thing that people forget is when you tell people they can't do something, then they are doing something else. So that's right. The other thing that we got wrong with the schools is like, well, if a kid is not in school, a lot of times they're in a daycare, they're being passed around among caretakers. And so I don't know. A lot of it seemed just about appearances and whoever the dominant political forces were making the decision who weren't willing to take that one particular risk, and not about overall societal benefit or health.
I think you just cracked the entire pandemic. Just that.
Thank you.
I think what you did was you're pointing out something I noticed. I just haven't articulated it in that way, which is that everyone who gets to make a decision, whether it be a school board, to a county commissioner, to a local health department, to a governor, to the president of the United States, the entire time has essentially been pushing the risk out of their field into other people's field.
Yeah. Oh, exactly. I mean, the most extreme example is like, the upper class, who get to sit in their nice homes every day, doing their Zoom meetings and ordering to-go food and pushing the risk on, the working class essential workers. I mean, yeah, I don't know. That's not a good functioning society that does that. It has to be about everyone's well-being. So
yeah. So I had Amish Adalj on the show in May of 2020. It's actually pretty remarkable. I've gone back and listened to that show since, and how much he got right. Even in May of 2020, he had infection fatality rate right around 0.5% overall. He had the idea that COVID already at that point in his mind was endemic. It wasn't going to go away like ever. And then there were all types of just kind of thing. Of course, he's a legit, expert in this area, and it was pretty remarkable. And I got so much pushback from audience members about talking about the statistics and the data in that way. And it's actually interesting because you tagged me in a thread on Twitter the other day where a lot of the same type of just bizarre conversations ensued, where in some people's mind, when they hear you say things like about 0.1% of kids who get COVID will go to the hospital, in some people's minds, they hear, so you're saying it doesn't matter?
Right. Yes.
Where does that come from? Why do people think that way?
That's actually a really good point. So I think that's an issue with, being an epidemiologist or working in epidemiology, is you look at, overall population health and overall numbers. And so you kind of like, have to look at the big picture, and that, that doesn't mean that an individual person's experience is not important, but you're looking at things like societal trade-offs and benefits, and like, the entire world doesn't need to change the way it does everything, because of, something that is extremely rarely affecting people. It's all about like, what is the cost of that trade-off, right? So, how many people are negatively impacted and how many people are positively impacted. And so, I think sometimes, it does come off like, that I'm minimizing, or people are minimizing the, when bad things happen, but that's, certainly not my goal, or I think any, epidemiologist goal, or any physician's goal who's trying to look at, harm reduction, and how can we, harm the least amount of people and benefit the most amount of people. And so there's always these trade-offs, and I certainly, have friends with like immune compromised children who are high risk. And, one of the things that I've also said is if, it's important to actually define which kids are high risk so that, when, if they're available for the vaccine, they can get it. So, that we are, identifying the people that need it and recognize that. And, but it's not like all schools need to close, because of a situation with a few children. I mean, I hope that comes off, in a caring way, because I really do care about individuals, and I care about the overall population health as well.
Yeah, and I feel the same way. I care about the kids that are affected by COVID, but I also care about the kids who are affected by what we do to prevent COVID.
Yeah, no, exactly.
It's a trolley problem.
Right. I mean, in the beginning, when we were saying like, oh, their kids are going to get depressed and kids are, going to have anxiety or other problems being alone. And even in the beginning, I thought, oh, well, it's just a few weeks. Like I was even one of the people who was like, kids are resilient. But of course, I didn't think that it was going to be going on for over a year. And I mean, now it's like, I've said this so many times, it's unclear to anyone what the end game of all of this is, especially if we feel like vaccinations are not totally preventing infections, they're preventing, severe illness. Like, are we going to forever be chasing cases and closing schools and masking kids? And like, what is the end of all this? So,
That's interesting, because that's actually another thing that was on the top of my head of when Dr. Adalja was on making predictions with me in May, was that he said, even if they make a vaccine, it won't prevent all the infections. COVID is not going to ever go away.
Yeah,
exactly. And people still don't get that. They think
right.
They think that we're buckling down. We're trying to do this one more thing until we squash COVID into zero. And that's a fantasy as far as I understand it.
I mean obviously I'm not an infectious disease doctor. I'm not a vaccinologist, but just yesterday I was reading the New England Journal of Medicine paper about the Moderna vaccines in children, and they estimated the efficacy of the vaccine in preventing infection to be 55.7%. It was very effective at preventing symptomatic disease, but not infections. So, right. I think that we just need to realize that, this game it's never going to end if we keep trying to just test for infections, and we should really be focusing on like preventing severe disease.
Right. Because as long as we continue to hold as our standard that all these mitigation factors and all these risk reducers are justified, as long as the risk isn't zero, then we will be doing these things forever. And I think that is the place that we're in right now in a lot of people's minds. And that's partly, I think, the rhetorical danger of why some people feel threatened to hear conversations like this, or they feel threatened to hear figures like, a 0.001% IFR for kids, or 0.1% hospitalization rate for kids. They hear that is so close to zero. Right. That almost goes in kind of on that sacred territory of, well, we're trying to get to zero, and the problem is you introduce the vaccines, and that reduces the risk even closer to zero, but it's never going to be zero. It's almost like I don't know if you've ever come across this. There's like a philosophical or mathematical thought experiment where, if I tell you go 1 mile away from me, and every time, and we each get to move, but each time we only get to move half the distance towards each other. In theory, we will never reach each other, no matter how many steps.
Yeah, that is a good way to introduce calculus. I mean, or that's a good example. I agree, and it's like, we take risks all the time in life, and I feel like people have lost touch with the sense of like how risky it is relatively for kids to go in a car versus their risk of COVID. I mean, in all age groups of kids, it's much riskier to ride in a car than it is for them to get COVID. I mean, according to the UK data, the risk of death from COVID was 6 per million infections. So they found 2 per million overall kids, but they've had a third who've been infected. So yeah. So I mean, I'm just kind of like reiterating what you're saying, that I do worry that there are some things that we take risks for without thinking about it, because we say, well, this is just normal life. And there's this disconnect between our willingness to just take this small amount of risk just to restore normalcy and to have a normal life. So I think people really need to think about, and this is something I think about a lot, like what is the value of a normal life, for a kid, for a normal school experience, for normal sports, like for someone to just kind of sit down and list or think about all of these benefits that you get from seeing, someone smile, from, having a discussion with your teacher without anything like getting in the way, and, from being able to go play basketball, with, I don't know, there's so many things that I worry like that the value of them is not being appreciated. Yeah, I mean.
Yeah. Yeah. And of course, early on in the pandemic, it was reasonable for some people to hear arguments like what you just made and say, well, yes, but what's the cost of a life? Right. And they'd say, okay, so the cost of somebody doesn't get to see someone smile at school. Okay, that boohoo, but there are people dying. Right. And of course, now what I feel like we should be able to do is I'll use the term mature the conversation. We can make the conversation more mature now, where we recognize that, yes, people are dying, but isn't it also good? Well, first of all, there is no good that comes from a global pandemic per se, but isn't it a positive or a silver lining that we could look and say, well, look at how much more we know now than we did a year and a half ago about how to predict with very statistical near certainty who is highly at risk from dying and how to protect them, what situations to put them in, so that we could potentially talk about how we could free up those kids to be able to have the normal life that they need in order for their neurological development, which is not just fluff.
Right.
There is once a kid's brain is fully formed, that ship has sailed. You can't go back and acquire language skills and acquire social emotional skills and acquire the ability to trust adults. Which is harder for young kids when they can't see facial expression.
Well, exactly. Yeah. I was just reading a literature review on that, actually, that was great. That was talking about all the data that we have about not being able to, have proper emotional development if you're not able to, look at people's faces. And I was going back and reading my literature about the, blind children and language development, about how that's behind. Not the kids who are wearing a mask are blind, but, we obviously use visual cues in a lot of things that we do. But, beyond just masks, I mean, that's obviously the hot issue right now, but like the long-term implications of, not having normal sports or PE, and sitting in your home alone during the day and developing, obesity and diabetes at a young age, like that can also lead to death. That leads to premature death, right?
Yeah, and puts you more at risk from COVID.
Is that not important? Right. And suicide risk from anxiety and depression. I mean, those are also deaths. And, the longer we continue to postpone, returning to normalcy and restricting what kids are doing, we are taking chances. And the diabetes rates in the United States already increased. Oh my gosh, what was it? I don't want to say the exact percent. I feel like it was a third last year, according to a poster.
Yeah. Well, I'd like to try to squeeze one more segment out of you, if it's okay, Tracy. I would like to get your take on the recent CDC update in masking guidance for the country. And in particular, I wanted to hear what you think about why, whether it be theories or if you actually know, why of all the things in the country that happen on a day-to-day basis, the CDC felt it was very necessary in July to specify schools in that guidance? Is there data that suggests that suggests that schools should be singled out and not churches, not grocery stores, not meat packing plants, not other things, but they named schools as a very specific place everyone should mask? That seemed odd to me.
Well, that does seem odd to me too. And I do not know why they did it, although I do know that there have been a number of studies done in schools where the fact that kids were masking has somehow become synonymous with, well, that must be the reason that there was such little COVID spread in the schools. So I was, obviously the senior author of one of those studies, the Wood County, Wisconsin study, where we had over 90% masking compliance, and we reported that. And that was, what was done in the districts that we were studying. Now, we didn't have a control group, obviously. We didn't have a group of unmasked kids. We couldn't say anything about what the effect of the masks were. But there was also the Duke, North Carolina study that came out around the same time. There was the Salt Lake City study. There were a bunch of school studies in the United States that came out last winter that all kind of talked about masking and talked about the low rate of spread that we saw in schools. And, in a non-logical way, decision makers, policymakers looking at these studies decided that it must be the masks. But of course, we don't know if it was the masks, because being a Scandinavian, I know that they never masked kids under 12, and they also had low spread in schools there. So we don't. So the answer is, I don't know. I think that they singled out schools partly because of those studies. It could partly be because of teachers unions. I know that teachers unions have been very involved in, the CDC's decision making around what sort of policies schools should have when they reopen. And that's, controversial as it should be, because, I think there should be lots of different groups at the table, including scientists and physicians, discussing what the best policies should be. But
imagine that.
But this is a long answer to your question that other than that, I don't know why they would single out schools, because, obviously other indoor situations with, especially, I would say, unvaccinated adults, like that's where you would want to take the most precautions. Now,
right. And that was partly what was puzzling to me, because I knew that teachers by and large have to be at a very high percentage of vaccination by this point.
Yeah, exactly. And now
it would be shocking. Like, it would be shocking to me if, at least in my school district, if we were under 90% vaccinated.
Right. Yeah.
And so that seems like kids, we talked earlier how low risk they are, and then we've got all these vaccinated adults. And correct me if I'm wrong, but even before the vaccine, the school, masked or unmasked schools from around the world, secondary attack rate, or attack rates in general in schools, are quite a bit lower than the general population, or at least let me rephrase that, not the general population, but other types of settings, like meatpacking plants, like care homes, like these other types of congregate living places. You'd think that if they're going to single out a high danger zone, it would be one of the high danger zones.
Right, exactly. So schools have, in general, masks or no masks, there's been a secondary attack rate consistently of less than 1%.
Right.
So that is very low. And there could be many reasons for that, but I certainly think that one of them is symptom screening. And that, people without symptoms, at least according to a very good study done in JAMA, they had a 0.7% secondary attack rate. So if you're asymptomatic, you're unlikely to spread it, mask or not, because that was in their own homes. Yeah,
that's a big misconception. Have you felt that too? A lot of the general.
I definitely felt that. And this is a disease with like a high K, right? So high dispersion. So there are super spreaders, and we continue to see this with the Delta, just as we previously saw it, that there'll be a person who, for whatever reason, it's, as far as I've seen, I've never seen a child that was a super spreader, though. Someone correct me if I'm wrong, but it's an adult, and there'll be a large outbreak. Typically, it'll be in an indoor setting, and then it's like, that can be enough to set a whole community on fire with cases, basically. Mm-hmm. So it's not surprising to me that schools, as long as kids aren't symptomatic, that their secondary attack rate, masks or not, is very low.
Yeah. Yeah, one of the things that, of course, I'll bring the music world back into this. We, in our professional organization, we sponsored, I'm not sure if you've heard about this, the professional singing organizations and teachers of singing organizations pooled our money together with University of Colorado and hired some of the aerosol scientists there to do a very large study on the way that aerosol particles operate in a room. And it's actually a pretty groundbreaking study. Now, the problem, my criticism of our world is that we now, because we were musicians and we sponsored this fancy study, that for many of my colleagues, that's the only study they look at. And so it's and the way I joke about it is that, okay, great, we know how spit flies around the room, but what we don't know is how that affects real people in real situations and whether or not it makes them sick.
Right, exactly. So that's the concept of the infectious dose, or around estimated to be around 1,000 virions, from what I understand. So you need a certain amount to infect you, and of course it depends on how robust your immune system is. And
right, they're averages.
Right? What'd you say?
They're averages.
Yeah, exactly. Mm-hmm. So you're exactly right. You don't know if just because there's some viral particles in the air, if they're going to infect anyone. You don't.
And am I correct? So I was just describing an aerosol study is similar to how they've been studying masks, which is that they're mechanistic studies. They study how the mask works. Like if I put a fan on one side and I blow air through it and I measure what comes out on the other side, again, that's good information. We want to know how the mask, what percentage of particles the mask stops and what percentage it lets through. That's good information, but it doesn't tell us enough information to make it a panacea. And
that's right, because you don't know about the real life effectiveness of it, and you don't know how many people will get infected. And gosh, it was just 2 days ago, I was looking at a kind of older study that was looking at influenza and influenza-like illness. And they basically, the conclusion was that cloth masks were inferior to the control, which was like, what? Was a little bit of a weird, conclusion. But we need studies we would need studies like that with COVID to figure out how many infections we're actually preventing. And we don't have any studies like that that I'm aware of. We just have the large population-based studies looking at mask mandates. And then we do have the Danish study that did that. There were some limitations of that study, but basically they found no difference between the masked group and the unmasked group in terms of getting COVID. As far as I remember, they weren't looking at giving COVID, but they were, transmitting it. They were looking at, yeah, that's right. So they were only looking at getting it, but they didn't have information about how much the control arm was masking, and they didn't have great information about the compliance. So I think that there were a few limitations of that study, but the end result was there was no difference.
That's actually, I think, one of my bigger frustrations with this tribe thing you mentioned earlier is I've been accused by many of being anti-mask. I'm not anti-mask. It's just that I know how they work. And so I would prefer that if my county, for example, wants to make a mask mandate, that they would post some of the readily available information to the public about which type of mask you're wearing and what type of situation it protects you in and which type it does not protect you in.
Yeah, for sure.
And nobody's the public health people are not doing that. They're just saying.
Yeah, I know. I think, even Michael Osterholm and Celine Gounder and stuff, they've been saying cloth masks probably aren't really that effective. And I think that's kind of the information a lot of us have been waiting to hear, because certainly, when I was concerned about getting COVID, I wasn't vaccinated. I have a lot of older patients, and I was like, I would wear an N95. I wouldn't, if I were concerned about getting or giving COVID, I wouldn't be wearing a cloth mask. I don't know, that was nonsensical to me. We don't have the studies to say they do absolutely nothing. But I think we do need a little bit of sort of honesty about, if you really want to be protected, you probably want to wear an N95 and not like a buff or something. I don't know, something. Yeah.
If you can smell food through your mask, you can breathe in aerosols.
Right, exactly. And then if it comes down to kids needing to wear N95s, then we're in trouble, because I don't see that being a good. Well, you could tell me how realistic that is, but I'm not seeing that.
Right.
Even my son already says we pull down the masks when the teachers aren't looking anyway. But
no.
With N95, it's going to be like, what? No way.
No, it's. I think people underestimate the how uncomfortable those can be when they're fit tested. But my goodness. Okay. So and I think that we'll wrap this up here in a minute, but that's again, one of my concerns, because I do have students that are legitimately immunocompromised. As in they had cancer in the last year and they've had chemo and there is no immune system. It's just gone. At which point, I'm concerned with the public health messaging that says, just wear your mask, masks work. Okay.
Yeah, I agree with that. I know.
And then they think they're safe, and then their parents think they're safe, sending them to school in a piece of cotton, rather than fit. Because if it's my kid who has just gone through chemo, and I feel like maybe socially he needs to be in school, and he can't do online school, he's got to be there, and because maybe he's having a mental breakdown or something, he's got to go to school. Fine, but I'm fit testing him in an N95 every single day. And that's, but no one's telling them to do that.
Right. I mean, and I wish that we could, for those kids, I just wish we had better guidelines about like, what is their actual risk, and like, what can they specifically those kids do, or even maybe those specific classrooms do in terms of improving ventilation. And, I think we just need to be more creative and more like, individualize with some of our responses, and not every kid needs to wear an N95 for 6 hours a day. Like that just is like, that's not going to be practical or reasonable. So,
Right. Well, okay, great. So you've been with me for an hour. I'm going to let you go, but I do want to just say on the way out, would you give some advice or maybe some key bits of reminders to teachers who are going to be going back to school this week or already have, regardless of whether or not they're in a masked school or a not masked school? How would you encourage them to think about that environment?
Absolutely. So, I mean, the number one thing right now is get vaccinated, for teachers and staff in schools to get vaccinated. And, I'm sure that most of them are. And once you are, you can really, breathe a sigh of relief, because if you get infected, it's very unlikely it's going to be a severe infection. It'll be a mild infection. And if you get a mild infection, if you get a case and, you don't have any symptoms, it's not a big problem. And so, I think we need to get used to the idea that we are probably all going to get infected. We may or may not have symptoms from it. It's going to be a circulating virus. And then, in terms of the kids there, to remember that overall, like, most kids are low risk. And if there's certain kids, who are felt to be high risk in that classroom, then, to look into that, ask, maybe the parents can look into that. But and like, especially high risk kids, adolescents, like, they're good candidates for getting the vaccine. And then, I mean, I guess I would say, like, that not to focus on fear too much. I guess I feel like, the amount of fear about what's going to happen once schools have opened has been exaggerated. And, I'm not trying to minimize it, but I found it interesting. Yesterday, it was a couple of days ago, I was reading the Danish newspaper, and they said, we've come to the terms with the fact that this isn't going to disappear, and we're accepting a certain amount of viral spread in the schools. I thought, oh, well, that's interesting. I mean, because they've just accepted, like, this is an illness that's going to be with us, and kids are mildly affected generally. So, but yeah, I mean, I think, what else can I say? I guess I think that's where I'll leave it, and say, like, remember, kids really, get so many benefits out of education, and to kind of like focus on the good that you're doing, and be reassured that, in terms of your own health, like, your vaccination is going to help you out, is going to be your best friend. So
yeah, absolutely. Well, thank you, Tracy, so much for spending an hour with us. I really appreciate all the information and helping us unpack everything.
Yeah, my pleasure. Thank you.
All right. Thank you, as always, for listening to an episode of the Choirosophy podcast. It's been a while since I've done a full-length episode, and I think this was a good topic to get back into the game after a summer vacation for me. So I appreciate you sticking around to the end. And of course, if you made it this far, that means you probably got something out of it. Hopefully in this episode, you got a lot of good information and a lot of good armament against a school year where you are going to be back in the thick of things. And that was my goal today, was to help you understand the situation that we are all walking into this next school year. And more importantly, the situation our kids are in, since they seem to be in the middle of the conversation yet again. So if you did get something out of this episode and you appreciate the content, there are some huge ways that you can help. Number one, and the freest way, is to simply share episodes. That's huge. It helps me beat the social media algorithm. Actually saves me money when you share episodes. That's big. Liking, leaving ratings, leaving comments. Those are all great ways to hack the algorithm. And then, of course, you can join the Patreon, patreon.com/Choirosophy for as little as $3 a month, and jump into that supporter community over there. And then, of course, there are great discounts for you at the 5 awesome vendors that you see in the banner behind me on the YouTube channel. vocevista.com/Choirosophy for resonance and overtone software, sightreadingfactory.com for your sight reading instruction, Graphite Publishing, and ryanmain.com for your online sheet music purchasing needs, and mymusicfolders.com for your resonance singer's mask, your choir folders, your choir robes at mychoirrobes.com. All of those websites take that Choirosophy checkout code to give you and your school budget a break with that discount code. Those are all ways that you can help out. So thanks a lot, and we'll see you next time.